Hi guys, good evening. Welcome to these deliberations here, and good to see all of you who have joined here, and happy to be of help just before the exams. Guys, I hope you're reading regularly, and importance is practice is perfect, but yes, perfect practice makes perfect. Please understand the importance of reading regularly. INI-CET is that one exam where most of the questions are the easy types. You'll think that this is the best exam you've written, but there will be those 20-30 questions which will decide your rank. So there are questions which are asked in great details, and that's why important to read perfectly and read regularly, right guys? So we'll start with a quick fire session about all the questions which have come in the recent exams and see how much we can revise in this session today. So guys, the first question here is in I mixed obs and gynae obviously, because I thought that to take two long sessions, I thought it is better that we take one good long session so that we can do as much as revision as is possible. So a 48-year-old woman presents to the OPD with heavy menstrual bleeding. A recent pelvic scan shows no pelvic pathology. An office endometrial aspiration shows simple endometrial hyperplasia with atypia. Now, which of the following is the most appropriate management? Now, when there is atypia, that's the problem. Hyperplasia of endometrium, cancer of endometrium, the age group is usually the 45 to 55 years of age. Do not forget diabetes mellitus, hypertension, obesity with irregular acyclical bleeding. We are thinking of endometrium. I said diabetes mellitus, hypertension, obesity. Please do not misunderstand CA cervix with this one. CA cervix is far more commoner in our country. All you interns and post interns have seen enough of CA cervix. Some of you would have seen a couple of cases of CA endometrium in your life, but you would have definitely seen those CA endometrium women to be a little more healthier and from the upmarket kind of society, okay, upmarket people, those people who are well to do. So CA endometrium questions will come, but remember CA cervix is the topic which you have to read very well. CA cervix in full detail. All right, guys. Now, this is endometrial hyperplasia. Endometrial hyperplasia can cause CA endometrium. We know that well. So, if you see this chart, this is a study which was there ever since the 70s, 80s, 1970s, 80s. This study, it is still valid now. The endometrial hyperplasia, if it is simple endometrial hyperplasia without atypia, the chance of endometrium is 1%. With it without atypia, in the case of complex endometrial hyperplasia, it is 3%. Now, with atypia, simple endometrial hyperplasia with atypia, the chance is 8%, and complex endometrial hyperplasia with atypia, the chance is 29%. Guys, they have asked you this, they have asked you the percentage also. The 29% used to come as a question in NEET exams. Remember this chart very well. Now, when there is hyperplasia without atypia, the chance is only 1 to 3% to have cancers. But if there is hyperplasia like in this question with atypia, these two, the chance of cancer is 8 to almost 30%. When we have this question, please understand the woman is only 45. She's already, I mean to say, already 45 to 55. There's no point conserving this uterus. So yes, when we have without atypia and with atypia, these two things are very important. With atypia, the question here, you have to do a hysterectomy, no doubt about that, okay? But without atypia, you can give a chance and you can give high dose progesterone therapy. This question has come so many times and this incidence has come so many times. So please remember, we are going to talk in terms of endometrial hyperplasia. Think that the woman is already 40, 45. Now, the other thing which I wanted to impress upon you guys here, look here. When we're talking about endometrial hyperplasia, woman has come with irregular bleeding. In the OPD itself, the first thing they've done is a office endometrial aspiration, office endometrial biopsy also you can do with the pipple. Irregular acyclic bleeding in a woman after 40 years. Irregular acyclic bleeding, a woman after 40 years, they can give you 45, 47, 49, whatever choice. Irregular acyclic bleeding, first to do is a endometrial sampling. Always endometrial sampling, endometrial histopathology, whichever way they ask you this question. First thing you have to do is that. So, endometrial sampling you have to do when there is a patient who's got this irregular acyclic bleeding. How you do the endometrial sampling? In the OPD, you can do something called the pipelle biopsy. In the OT, you can do a DNC or you can do a hysteroscopic biopsy. So please, these three things, how you take the sample, it depends on the location they've asked you about. So first thing, always say endometrial sampling. Don't say I will give this hormone first, or don't immediately jump to the answer hysterectomy. These are all wrong answers. Okay. So pupil biopsy is around 80 to 90% sensitive in picking up endometrial cancer if it is there. Then DNC is 95 to 99% sensitive, and hysteroscopic biopsy is 100% sensitive in picking up a endometrial cancer if the patient is having it. So please remember, endometrial sampling, okay, extremely important, right, guys? So common cannula, no, common cannula doesn't come here, guys. Common cannula comes in when we're doing a MTP. So in the OPD, when we're doing it, it's called the pupil biopsy forceps, right, guys? We'll move on and we'll see the next question. A 39-year-old woman who is para 3 live 3 complains of severe progressive secondary dysmenorrhea and menorrhagia. Pelvic secondary dysmenorrhea. Secondary dysmenorrhea is that congestive dysmenorrhea, too much of pain, right, guys? And there's a diffuse enlarged uterus of around 12 weeks, pregnant size. 12 weeks, pregnant size. She's not pregnant. Please, we gynecologists have a habit of relating any mass in the pelvis to the uterus of a pregnant lady. There's a 12 centimeter mass. Let's say a woman is even 80 years of age and there's a 12 centimeter mass. I'll put my hand and say, yeah, there's a 12-week size mass. It's a thing in gynecologists, you know, we just keep relating the pregnant size because we are very used to seeing pregnant ladies. So when we say a woman is having a 12-week size mass, it is roughly 12 centimeter size mass. So do not get confused that this is a para 3 live 3 who is 39. She's having an enlarged uterus. I'm not saying she's pregnant. I'm saying it's a pregnant size uterus. Okay, this is how we talk in amongst gynecologists. Okay, so don't get confused. So yes, this uniformly enlarged, okay, diffusely enlarged uterus. So I'm trying to say that it is not fibroid uterus because fibroid will be irregularly enlarged. So uniformly enlarged uterus, diffusely enlarged uterus, around 12 weeks, para 3 live 3. So of course it can be adenomyosis, but it cannot be endometriosis. Endometriosis will have problems in the ovary. It can be endometritis. No, endometritis will not have a uterus enlargement. Uterine sarcoma is not so common, first of all. So, and it might not be so uniformly enlarged all the time. So, uterine sarcoma is a rare cancer. I've seen only a very few in my life. And adenomyosis is the very common condition which is seen in women who are between 40 to 50 years of age. So, I hope all of you got this. This is a likely case of adenomyosis. And remember, when we are talking about para gravida, we are using the gravida para live aborta formula only. The gravida preterm term live aborta, this formula we are not using. Okay, guys, that is used in some localities in the US. We are always asking you questions. All exam, whichever exam the question has come, it has come in GPLA. And when a woman is not pregnant, we don't put a G. So this is para 3 live 3. We would write it as para 3 live 3 also. Please do not put a G unnecessarily. A G comes only when a woman is presently pregnant, right? So let's move on and see. This is that uterus which is uniformly enlarged. This is from my path lab in St. Stephen's Hospital. Here you're seeing the uterus is uniformly enlarged. The cavity here, this is totally compressed by the myohyperplasia, and you can see these lakes of menstrual blood in the myometrium. These lakes of menstrual blood are there because the blood from the cavity has seeped into the uterine muscle. Now, when you see this blood, it is looking black to you because this tank is of formalin. So the formalin will cause denaturation of the hemoglobin. That's why it will all look black to you. So adenomyosis, this is the case, and what are you going to do? The best treatment, yes, you can give medical relief in adenomyosis. The best treatment of adenomyosis is to do a hysterectomy. Yes, you can give relief. You can buy some time. A lot of times these women are mostly around 40 and they'll have 40 to 50, 45 years of age, and they'll have children who are going to school and college and maybe exams, maybe Holi Diwali. you know, some function is around the corner, Eid is around the corner. So they'll say that, sir, right now I don't want to have a surgery. Can we buy some time? So GnRH and LOVES is my best management. If they ask you medically, we can suppress the periods, we can suppress the pituitary, suppress the periods. She has good relief. She will not bleed and she'll gain a hemoglobin. She'll gain in her health, and we can buy some time before we do a hysterectomy. But if they ask you the best treatment, go ahead and say hysterectomy. The best medical management is to do the GnRH envelope therapy. Okay, how do you diagnose? Yes, now diagnosis of adenomyosis. Yes, I'm seeing some chat here. Meaning of this, you understand, you cannot put a laparoscope here. You cannot put a laparoscope in the abdomen and see. The uterus will be uniformly enlarged. And you cannot put a hysteroscope also. You cannot put a hysteroscope into the cavity because you cannot see outside the cavity. So neither laparoscopy nor a hysteroscopy. You have to take a uterine biopsy. So the biopsy of the uterine muscle will show us blood-filled macrophages. Blood-filled macrophages. Okay. Guys, so I think we'll use dark blue for the time being. Okay, Hindi mein padao. Guys, Hindi or English or Tamil, it's going to be very difficult to choose. We'll have to stick to English. Ilana nare pera Tamil kepanga, and we cannot do Tamil because a lot of you will not understand that. So I guess we'll stick to the language which is accepted as the mode of instruction. So we'll stick with our good old English. Right, guys. So let's move on and see the next question. Woman who is 26 years with PCOS and infertility received clomiphene citrate therapy with injection FSH on day 6 and day 8. Please consider this is somewhat different from the regular question which you expect to read. So a PCOS woman who is infertile has got injection FSH on day 6 and day 8 and day 10. That is, she's got 3 injections. Trigger was done on 14th day after follicular monitoring, showed 4 follicles, and they weigh 18 to 20 millimeters in size. Just forget this part, 18 to 20 millimeters in size. On the day of her anticipated period, she complains of abdominal distension, vomiting, abdominal pain, and bloating. UPT is positive. She's got pregnant. Ultrasound reveals moderate ascites and thickened endometrium with clear adnexa and bulky ovaries. Which of the following is true of her condition? They're trying to say the adnexa is clear, there is no ectopic pregnancy, the ovaries are bulky, there is no free fluid. And they're trying to say that the patient is not a ectopic ruptured pregnancy. That's why they're trying to give you this abdominal ultrasound picture. There were 4 follicles, and generally there is 1 follicle when we do the ultrasound for any woman who is having a menstrual cycle. Now there are 4 follicles, and she's a case of PCOS. We give in injection FSH, but now she's got pregnant. So when a woman is pregnant, HCG will increase, and when there are 4 follicles, the HCG will increase. And this woman who's having high number of follicles, there is high estrogen, then there is the high HCG because she's got pregnant. So this will increase the vascular endothelial growth factor, which will cause the woman to have ovarian hyperstimulation syndrome. Now this is not coming into the regular story which you have heard, isn't it? You'll generally see a picture with a lot of small follicles and a lot of big follicles, all mature follicles, and you think it is OHSS. Correct, that's the picture which will come in exam. But INI-CET, they'll ask you OHSS which has come late onset. This is the OHSS which has come to a woman who is pregnant, and now the HCG is increased because of 4-5 follicles. The estradiol, the basal estradiol was high, and the HCG can also increase because of pregnancy. So normally you've heard of OHSS, high estrogen, high HCG given for the maturity of the follicle, and that causes the increase in VEGF, and that VEGF increases the vascular permeability, and that is ovarian hyperstimulation syndrome. You're used to seeing this picture, yes? All of you expecting this picture. Yes, this picture is OHSS. You know, the multiple follicles which are ready and all of them are big. This is OHSS, correct? But the question here asked is OHSS which is late onset, guys. So remember the early onset OHSS. I'll write here, early onset OHSS is the 3 to 7 days of giving the HCG when the follicles are getting ready, when we're giving her the infertility treatment. And the late onset OHS is the one which is around the 12th to the 17th day of the HCG injection, because now the patient has implanted the embryo and the embryo is increasing the HCG, and that high HCG is causing the late onset ovarian hyperstimulation syndrome, and that is far more problematic, okay guys, because the HCG is now going to progressively increase because she's pregnant, and in pregnancy HCG goes on increasing. What will you do, guys? Don't look at the question. I'm asking you a very, very important question. Yeah, if a woman is pregnant, ovarian hyperstimulation syndrome has happened as a late onset, and the HCG is going to progressively increase, it can kill this lady. I'm telling you, the OHSS can go to the critical form very easily. So what are you going to do? You're going to do an MTP. Yes, this is a indication for doing an MTP for this patient because she's pregnant and the HCG is going to increase, and with a basal high VEGF super added HCG, she can get very sick, and you have to end up doing MTPs in such patients. All right, she came to you for infertility management. She has OHSS, which is a totally iatrogenic disease, and with OHSS she can die. You have to end up doing an MTP sometimes. So please understand, late onset ovarian hyperstimulation syndrome is the answer here. Now, this is the picture of a normal regular OHSS which you see in an IVF. There are more than 20 follicles ready, both the ovaries put together. If there are more than 20 follicles ready, we say it is OHSS, and that is the regular, the early onset OHSS which you guys have known. Now, the category, this is the Mathus classification which is accepted by the Royal College. So, this is mild, moderate, severe and critical OHSS. Generally, the ovarian size is less than 8 centimeters in mild form. Anything more than 8 centimeters is a next stage, that is the moderate ovarian hyperstimulation syndrome. And now you will start having ultrasound evidence of ascites. Severe OHSS, you will have clinical ascites. That's the difference. Clinically, you can see that the patient is having a bloated abdomen and you can feel the shifting dullness on the abdomen, and the ovarian size will be more than 12 centimeters. And very important, look at the hematocrit. Hematocrit is increasing. What 0.45 means 45% in if you convert it. So 45% is the hematocrit. Hemoconcentration is happening, and critical OHSS hematocrit will be more than 55%, and there will be oliguria, there will be thromboembolism and respiratory distress syndrome. So remember, less than 8, 8 to 12 and more than 12. They have asked you this in PG exam long back when PG exam was a separate exam. They have asked you what category of OHSS this patient is. So INI-CET, they can ask you an occasional tough question. Right guys? So that is OHSS. This is the lady. I was just trying to tell you that OHSS does happen. This is one of my patients, my hospital. This lady was around 5 months back. She had this ovarian hyperstimulation syndrome. She had 47 eggs, but yes, she's absolutely fine. Don't worry about her, because we took out her eggs, we made embryos and we froze the embryos. The extra embryos are always frozen. Those embryos are not used, because if you use them and put them into the uterus, she'll get pregnant and she'll have this late onset OHSS. So all the extra embryos were frozen. Now this woman, she has an abdomen which is bloated. We have done one tap yesterday. We have done one tap today also. That is, we have done 2 taps. This is the tincture benzoin seal which we have put after doing the tap to prevent an infection. So yes, you keep on taking out the fluids from the ascitic, from the abdomen, the ascitic fluid you keep on taking out. You keep taking out the pleural fluid, and intravascular compartment there is hemoconcentration. You keep giving IV fluids and oral fluids. So keep giving fluids, keep taking out fluids. This goes on for 5-6 days. Eventually the estrogen is metabolized by the liver and the patient gets better. So you can see the abdomen wall and the back all edema. You can see the labial edema here. One labia is literally hanging because of the abdominal wall edema here. Right guys, let's move on and see another question. A 30-year-old woman presents with excessive facial hair and hair over her upper arms and back. Such growth has been rapidly increasing over the past few months, and she also complains of hoarseness of her voice. Her abdominal ultrasound shows a ovarian tumor. Which of the following is the most likely tumor? So yes, before we give you this answer, I want you to understand what is the most common cause of hirsutism. That this line has to be very clear in your life. It is PCOS. If you see a hairy girl, it is PCOS. Khatam. Don't get into any confusion about that. PCOS is the most common cause of hirsutism. Yes, there can be idiopathic hirsutism, 25%. They can be ovarian tumors. They can be adrenal tumors. See, this is an ovarian tumor which is causing. They can be congenital adrenal hyperplasia. They can be Cushing syndrome. There are many causes of hirsutism. But 70% of hirsutism we say, or forget the percentage because that is a little controversial, but most common cause of hirsutism, straight away PCOS. Do not miss on that line. Now, when you see a girl with PCOS hirsutism, it's a girl who is normal type of a girl. You look at her, she'll look like an absolutely normal girl. She'll have some androgenic disturbances. I'm talking of PCOS. She'll have some androgenic disturbances. She may have a little bit of a mustache and a little bit of prominent chin hair, which she's taking out by the cosmetologist. She may have some excess body hair. She may have some more acne compared to others, but her face is feminine. Her hair are mostly feminine. Male pattern baldness doesn't come to most women with PCOS. So she's not virilized. PCOS girls are having hirsutism, but they are not virilized. Adrenal tumors, ovarian tumors, congenital adrenal hyperplasia, they become manly, virilized, broad shoulder, no breast, breast will become atrophic because of the high androgens, clitomegaly, hoarseness of voice, and facial features which are very coarse, there'll be a very prominent chin and a rough skin. So imagine my kind of face and the person is a lady, that kind of coarse faces. So that kind of thing will be there in a woman who's got an adrenal tumor. So adrenal tumor, ovarian tumor making androgens. We also call something, we also say rapid onset hirsutism with these tumors. So yes, this is an ovarian tumor. Granulosa cell tumor makes estrogen. Sertoli Leydig cell tumors is the answer here. It is making a lot of androgens. Teratoma, PCOS. Now, this history is not sensitive of PCOS. Okay, there is an ovarian tumor. PCOS is not a tumor. PCOS is a slightly enlarged ovary. Do not say PCOS has a big ovary. Polycystic ovary is a misnomer. I have told you many times. Polycystic ovary में cyst नहीं होता है. Okay, there is no cyst in PCOS. It's just a slightly enlarged ovary with multiple small follicles in the periphery. So this is an ovarian tumor with Sertoli Leydig type. Right, guys, testosterone levels. PW app is all getting ready, guys. We should be able to give you all the lectures very soon. What else are you guys asking me? Let me see what are the other questions you've asked me so far. Get around 20 odd questions. Okay, fine. Not many questions. We'll move on. Next question. Okay. A 54-year-old woman undergoes a laparotomy because of pelvic mass. At exploratory laparotomy, a unilateral ovarian neoplasm is discovered that is accompanied by a large omental metastasis. Frozen section diagnosis confirms metastatic serous cyst adenocarcinoma. There is a serous cyst adenocarcinoma. The most appropriate intraoperative course of action is, please remember, a woman 50 to 80 having an ovarian tumor which is looking as if there is a omental metastasis already. So if there is omental caking, mostly they'll write omental caking. The omentum gets clumped, it gets bunched up because of the metastasis, and it becomes like a big, cake kind of, one big box of tissue. It looks like that. So omental caking, if you see, then you're very sure that the woman is already having involvement of the omentum with the cancer. So what are you going to do? You're going to do a surgical management to first assess the stage, then remove as much as you can remove, and then give the chemotherapy. Okay, so we don't say omentectomy and ovarian cystectomy. We say the whole abdomen, whatever is involved. Look, when you open the abdomen in ovarian tumors, there's nothing like a total abdominal hysterectomy with bilateral salpingo-oophorectomy. This line will not be there in any book. In ovarian tumor, you take out whatever has to be taken out. You open the abdomen and you see a growth of 20 centimeter in the right ovary, and the omentum is involved. So you have to take out the right ovary, you have to take out the left ovary and the uterus, because the woman is 55. Because the other ovary will soon get involved and the uterus is involved. That is second stage of ovarian cancer, isn't it? The stage 2 is uterus involvement, 2A is uterus, 2B is other pelvic organs. Remember? So uterus has to be taken out. But the omentum also has to be taken out in this patient because it is involved, and whatever else you see. So we say maximal cytoreduction. Maximal cytoreduction is the term. Maximal cytoreduction in ovarian tumors. Okay, we don't say TH and BSO. So whatever is involved, we have to take out. Now suppose this girl had an ovarian tumor, maybe a malignancy, and she was only 19. Then you take out only the ovary, and the other ovary is fine, and the uterus is fine, and the all other abdominal organs are fine. They are having no involvement. You just take out one ovary and you save the ovary because she's only 19, because she wants it for the menstrual function and also for the pregnancy function later in her life. So that's why we say it depends on the age and the stage. You do not take out all the uterus and both the ovaries in all cases. It depends on the age and the stage. So the punchline here is maximum cytoreduction, or we also call it optimal cytoreduction. Right, guys? So these are the steps of the staging laparotomy, and please read them at leisure, because this is extremely important. I'll move on here so that you have a full complete screen for you to pause and read. Vertical midline or paramedian incision, ascitic fluid and washing the stent for cytological evaluation. If there is no ascites, we wash the abdomen. These steps have come in your INI-CET and also in the MCA exam. Which of the following? All of the following are seen, all of the following are steps of a staging laparotomy, except like that these questions have come. A systemic clockwise exploration from cecum upwards, and that's a clockwise exploration. Suspicious areas are biopsies, and diaphragm should be scraped, and a supracoelicomentectomy. Even if the omentum is normal in a case of ovarian cancer, we must take out the omentum, so that if the path fellows will tell us later, the pathologist tells us a report after 5 days that the omentum which you send, it looked apparently normal on the naked eye, but when it did a estimation on histopathology, we saw there's a micrometastasis in the omentum. If the omentum has micrometastasis, that means the patient already has involvement in the abdomen. That means it is now stage 3A, 3A2, that is microscopic metastasis in the abdomen. Okay, biopsy of pelvic and parotic lymph nodes and remove all gross disease. Right, guys? So, okay, so Meet Khatri has asked me the question which is very, very difficult to answer in this, but I will try and help. That what is the reason of this post-menopausal bleeding in our country? So post-menopausal bleeding. So before we go here, I have a empty screen here. So post-menopausal bleeding. Look, whatever happens, please mark CS cervix. You have to understand, all of your interns, and we'll quickly do this. Post-menopausal bleeding in India, if they ask you, CA cervix. Post-menopausal bleeding, they don't write India. So what are they asking you? You're writing your INI-CET, NEET PG, MCI to get seats where? In central London or in Boston? Where are you trying to get your seats in? We're not bothered about the world, guys. We are going to ask you what you've done in your life as interns, what you've seen in the OPDs, and in OPDs you've seen CS cervix. As simple as that. Yes, it is CS cervix. Look, if I ask you what is the most common heart disease in pregnancy, yes, come, I'll see the answers. What is the most common heart disease in pregnancy? Come, answer, I'll see. Heart disease in pregnancy, guys, write fatafat. Let's see what you're writing. Ischemic heart disease, wrong. That's a wrong answer. Ischemic heart disease. Pregnant women are very easily protected against coronary heart diseases. Women, in fact, are prevented till 50 years. So that's a wrong answer. The most common heart disease in pregnancy is rheumatic heart disease. Whether I ask you India specifically or I don't ask you, we're asking India only. And we have so much of rheumatic heart disease and we have so much of mitral stenosis. So there you will not have any doubt, because whenever they ask you this question, you will immediately say it is mitral stenosis because of rheumatic heart disease. But when I ask you about C endometrium, you start thinking about the West. Please, guys, CA cervix. You interns, when you have gone to the OPD of gynae, all of you have seen CA cervix. A few of you have seen endometrium. Any one of you, please raise your hand. There is a doctor who is already writing senile endometritis. Can you please tell me, Jadhav, how many cases of CA cervix you've seen and how many cases of senile endometritis you've seen? You've done your internship, that's why you're writing INI-CET, I'm sure. Tell me, how many cases of senile endometritis you've seen? I've asked this question to so many students over the years when they are in the discussions with me in the classes, the PG entrance classes especially, that they keep answering senile endometritis. The next question is, how many cases of senile endometritis you see? How many cases of CA cervix you've seen? Have you seen CA cervix? Everybody raise their hands. Which one do you see? You see CA cervix. Senile endometritis, yes, it is there. We have seen, I've seen quite a bit, but I have seen so much of CA cervix that there's no comparison. So there's a study which I cannot quote here which I cannot show here right now. It's an Indian study. It's a 22-23 paper of our country, and they've given you the histopathological correlation of, it's in the Journal of Obs and Gynae. I'll probably try and show you if I can during the lecture itself. Probably I'll post it later. It is showing you exactly 39.5% is the incidence of postmenopausal bleeding because of CS cervix, and polyps, senile endometritis, see endometrium is all around 10 and lesser percentage. Senile endometritis only 2.5%. We're talking India, please. So if they ask you postmenopausal bleeding in India, if they don't ask India, please write this. Now the problem is, you guys get confused. What if they ask about the world? I'm not going to ask you about the world. If they ask you about the world, it is an unfair question, but let me tell you very simple logic. What is the world? India and China is 55% of the world, guys. India and China is 55% of the whole world's population, and we get CS cervix. So the world finishes here, man. 55% of the world is in India and China. Just in case we are running short of numbers, whole of Pakistan, Afghanistan, Kyrgyzstan, Kazakhstan, Uzbekistan, and Nepal, Bhutan, Sri Lanka, it's all like us. People are like us in all these countries. Whole of Africa is probably worse. Whole of South America is like us. The whole world is like you and me, guys. We are the world. Yes, we are the world. The majority of the world, you have read it in PSM, the demography, they've taught you that 80% of the world is underdeveloped people or developing people. 80% of the world. Only 20% of the world, I might be a little rough in the figures, only 20% of the world is developed. So when they ask about the world, why are you getting confused? So when they say India, you write India answer. If they don't mention India, they're not meaning the world. Even if they're meaning the world, it is the same, because people like you and me are the commonest people in the world. Yes, people like you and me, the black and the browns, are the commonest race in the world. So yes, you asked me a question which I told you is a little touchy for me, because it gets extremely difficult for me to explain it repeatedly, the same funda, that when we are talking about India, you are asking Indian questions only all the time. But if you're not mentioning India, you're still writing an Indian exam. You cannot say that most common heart disease in pregnancy is congenital heart disease. That's what is written in Williams Obstetrics. Yes, my favorite book. It is congenital heart disease in the West, in Europe, because they don't have rheumatic fever. So what are you going to write? You have seen only rheumatic heart disease and mitral stenosis in your life. So this, please rewind this segment and please hear it again. It is for your benefit. It is not just for this particular question. It is for you to understand what are you going to ask you in the exam. This INI-CET, this is, one of the colleges where I've done my MBBS and MD. So my MBBS and MD, when you've done it from there, I understand why they're asking you such questions. Yes, it is extremely important to understand that we are asking you what we are seeing in the OPD. And you've all seen CS cervix, and I don't think any one of you seen senile endometritis. The discussion finishes there. In the West, yes, in the West, you can say in the West it is senile endometritis, and you can say hyperplasia and polyps. Polyps are there in India also. Senile endometritis is there in India also, but it is not so common. All right. So CA endometrium, hyperplasia of the endometrium, all of these will come more commonly in the West. India will say CS cervix. Chalo, let's not spend more time here. Let's move on to the next question. A woman underwent a gynecological surgery and on third post-operative day developed falling urine output and right-sided flank pain. An abdominal scan done revealed a right-sided hydroureteronephrosis. Somebody is likely to the ureter while doing a gynecological surgery. Which of the following surgery has the highest risk of this complication? So remember, when we have more extensive surgery, more likely chance of injury. So anticolporrhaphy, vaginal hysterectomy, Wertheim's and abdominal hysterectomy. Out of all these four, Wertheim's hysterectomy, the modified Wertheim hysterectomy, involves cutting of taking the uterus away. Around half of the ligaments, round ligament, Meckenroth ligament, uterosacral ligaments, you cut them almost more than half. And then we also do a pelvic lymphadenectomy. So that's why it's called the modified radical hysterectomy, the Wertheim's hysterectomy. The Meek's hysterectomy is the type 3 hysterectomy. Wertheim's is the type 2 hysterectomy, and we call it modified because the lymphadenectomy is also added to this. So this is mostly the more common. I'm not saying most common, it is the more common radical hysterectomy done in our country, and that's why you have this as a more extensive surgery, more lateral part of the pelvis involved in the surgery, and while you're doing the surgery, you can cut the ureter more likely than other places. Guys, then a 17-year-old girl presents with primary amenorrhea, well-developed breast, and scanty axillary hair and pubic hair. Ultrasonography of the patient shows absence of uterus and vagina. Genotype of the patient is most likely to be scanty axillary hair and pubic hair. Always remember any case of intersex, see whether the pubic hair is shown to be present or absent. Always say that, because if the pubic hair are present, that means the androgen part is working. So pubic hair are because of androgens in men and also in women. Boys and girls both have pubic hair because of the androgens. So now pubic hair is scanty. That means this girl is not having enough androgens, and there is primary amenorrhea and a well-developed breast. So yes, first of all, this person is not having the androgens working. That means there is an androgen insensitivity. So that makes her answer much easier now. When there is androgen insensitivity in a boy in the intrauterine life, these androgens are not working, so the external genitalia does not take the shape of a boy. The default sex organ, the default sexuality, the external genitalia, the default sexuality is the female form. And in the intrauterine life, if there are androgens, it makes a male. If there is no androgens, then it makes a female. So yes, now the person has androgens, but the androgens are not working. That means it's a boy. When the androgens are not working, so by default the external genitalia becomes like a female. So looks like a female, but does not have pubic hair and axillary hair, androgens not working, and has well-developed breast. Well-developed breast, there will be large breasts, but there will not be tan of 5, there will be tan of 4. There will be a large breast, but the external appearance of the person is of a tall, broad female with testicular feminization syndrome. It's actually a boy who's looking like a tall and slightly broad-shouldered lady with the breasts and totally feminine. In fact, very excessively feminine at that. We say they are they are pretty girls. Actually, these testicular feminization boys, they look like very pretty girls. So yes, this karyotype is going to be a 46XY. This is a case of testicular feminization syndrome, which is the worst form of androgen insensitivity syndrome. The different grades of androgen insensitivity syndrome, please find time and read about that. And the worst type of androgen insensitivity syndrome looks like testicular feminization syndrome. Right, guys, sound coming slowly. B team, can you just help me with this? Guys are not able to hear me too well. Yeah, I think keep moving. Yeah, a 7-year-old girl is brought to the physicians by her mother as she has started to have cyclic vaginal bleeding since 3 months. 7-year-old girl, please, the age is important here. And she also has started showing signs of breast development and growth of pubic and axillary hair. It's a case of precocious puberty. Her LH and FSH are to be in the range similar to reproductive age. Okay, so the spurt of GnRH has already started much earlier. So this is a case of precocious puberty. Which of the following is the most appropriate pharmacotherapy in this case? Remember one thing, when a patient has precocious puberty, especially in girls, you know the chain of events. Yes, girls will have breast, then axillary pubic hair, then the height will increase, and then the periods will come. So moment the periods come, the height stops. So that's the punchline of this. Moment the periods start for a girl, that is the time when the height will not grow. The day she gets a period, you can make her stand next to a wall and mark the height on the wall in your house. That's the height she's going to have. Maybe another 1 centimeter she'll grow because of the epiphyseal fusion, which is going to take next 3-4 months, but the height is not going to increase anymore. That's why we say that once the girl has had her periods, the height will stop. That's why precocious puberty is bad. All of you keep thinking about precocious puberty, the age is this and age is that, and you have confusions. Look, 10 to 12 is normal, and if she's got periods 9 to 10, it's early, and 8 and before is precocious. 8 and before is precocious, straightforward given in Novak's Gynaecology, so don't have any confusion on the figure. But if the woman is getting periods at 7 years, if the girl is getting periods at 7 years, she's getting precocious puberty, I don't want her to have a short height. So I immediately stop all of this pituitary activity by suppressing the pituitary. So which one do you think is going to suppress the pituitary? We're going to suppress the pituitary by GnRH agonist. The continuous administration of GnRH antagonist is going to suppress the pituitary, and we're going to give the treatment to accelerate a growth. Exogenous growth hormones can be given for the person to attain a reasonably acceptable height. Right, guys, a 25-year-old woman presents with dysmenorrhea with regular cycles. On examination, the doctor explained that the pain is due to acute retroverted uterus, which is an abnormal position of the uterus. Yes, retroverted uterus, whether it's in a normal woman, a non-pregnant woman, or in a pregnant lady, it can be a cause of a lot of pain. So retroverted uterus can cause pain because of the reason being also endometriosis. Endometriosis cause adhesion. There can be a fixed retroverted uterus also. So which of the following responses for maintaining this normal position of anteversion? Anteversion is normal, retroversion is what has happened in this patient. So anteversion is maintained by which ligament? The round ligament. I keep telling you with my hands like that. Yes, the uterus is this is the round ligaments, and these round ligaments go from the top of the uterus, go to the deep inguinal ring, go to the inguinal canal, and then they go and hold the labia majora. So yes, this round ligament causes the anteversion. The anteversion of the uterus is because of the round ligament. So yes, the answer is round ligament. You can see that here, the round ligament here, it is coming like this from the side of the uterus, top of the uterus, from the sides it comes out, and this is going to cause the anteversion. The angle of anteversion is 90 degree. The anteflexion is the uterus flexing over the cervix is anteflexion. This is 125 to 170 degrees. Some books will say 170 also. So don't get confused. This can vary, the anteflexion. Anteversion is generally around 90 degrees. That is maintained by the round ligament. A 32-year-old para 1 live 1 presents with postcoital bleeding. On examination, there is a hypertrophic cervix. This is why I keep answering what I answer. Hypertrophic cervix. The ultrasound shows a normal endometrial cavity. Which of the following the next best step in management? So we keep asking you, what is the management of postcoital bleeding, and you always end up saying pap smear. You can do a pap smear. I'm not saying it is contraindicated to do a pap smear, but guys, pap smear is only 48% to 62% sensitive. It is going to miss. It is going to miss in roughly 55% of cases if something is wrong. It's a screening test. So when a woman is symptomatic, postcoital bleeding, what is the most common symptom of CS cervix? Guys, this is extremely important. Most common symptom of CS cervix is postcoital bleeding. The patient has come to you with postcoital bleeding, and you're going to do a screening test, a pap smear. Please listen to this segment very carefully. You're not going to do a pap smear as the best management. You're going to look at the cervix very closely with a colposcope and look for abnormal areas. If you cannot see with the colposcope, you use highlighters like acetic acid or iodine, Lugol's iodine, Schiller's iodine, or you do a green filter. Yes, green filters come in your exam, guys. So you look at the cervix with a colposcope and take a biopsy, because postcoital bleeding means there is something wrong. It is not just a screening test. So pap smear may miss. I'm not saying pap smear is the first. I'm not saying that you should not do a pap smear, but it is definitely not the best thing to do. So remember, the best thing and the first thing which I will do, and that is your answer, is a colposcopic biopsy. Guys, do not do anything else. Now, they have asked, this is a INI-CET question. I know how this has come, because it's a very important regular ward rounds question for us, that what do you do when there's a hypertrophic cervix? The cervix is not normal at all in the first place. When it is hypertrophic, you look at the cervix with a colposcope. So this is one step ahead of what I was trying to say. If a patient has postcoital bleeding, do a colposcopic biopsy. If it has got a hypertrophic cervix, you definitely have to go ahead and do a colposcopic biopsy. Okay, guys, and if this does not show me the next step question, you know, who knows, this time they're going to ask you that. If this does not show me, the colposcopy is not definitive, you don't know, you're not getting the right answer with the colposcope, then you have to go and do a conization next. Guys, she is 32 and has one child. That's why we are doing colposcopy first, and conization is not the best option when the girl is young. So remember, colposcopic biopsy. Yes, I'm hoping green filter for abnormal vessels, and most of you saying B. I'm so happy. Oh, guys, I'm able to make you think. I'm so happy, guys. Thank you so much for remembering that it is colposcopy. Let's move on and see something else. A lady with 38 weeks of pregnancy presents with first episode of painless vaginal bleeding. Painless vaginal, 38 weeks of pregnancy. On examination, HB is 10.5%. BP is 124/78. Uterus is relaxed and head is unengaged and floating. Fetal heart sound is regular. Line of management is So painless vaginal bleeding, this word is very important. Painless vaginal bleeding at term. We are not going to give you more information. Obstetrics, term pregnancy, painless vaginal bleeding. It means only one thing, it is placenta previa. Vasa previa is so rare that I have seen one case. Guys, I have seen enough velamentous cords in my life. Vasa previa bleeding and the baby getting sick, I have seen one case. In placenta previa, we see even day before when I was doing ultrasound, 3 patients I did early pregnancy ultrasound, 2 had placenta previas. Later they become all right also because of the placenta migration. So placenta previa, so we see so much more. So placenta previa, painless vaginal bleeding. Okay, think of that. Now, what is going to happen if a patient is bleeding at term and there is a placenta previa? Then you're not worried. You know, it is already a case of diagnosed placenta previa and she's having the bleeding already. Resuscitate and operate. So this is the best answer. So blood transfusion, some of you may say, so first blood transfusion and then do the surgery. Yes, I would say along with the resuscitation, do the cesarean section. But here the hemoglobin is fair. You're not seeing that the patient is getting. So I'm not saying don't arrange blood. Please arrange blood. But the better answer is immediately plan for a cesarean section. Don't waste time with blood transfusion because it's going to take almost 4 hours to finish 4 to 6 hours to finish a blood transfusion. Even if you rush it, it's going to take half an hour. In that time, you would have already taken out the baby in a case of a emergency like this patient with placenta previa. You would have taken out the baby. Okay? So go ahead and say cesarean section. Identify this instrument, guys. Come, guys. Identify this instrument. Ah, come on. This is a simple one. So please, this has got a lock here. Okay. So this is a speculum with a lock. So this is why we call it the Cusco speculum. The Cusco speculum is the one in which you can open the vagina and keep it opened with this lock. You can screw this lock, and with this you can look at the cervix to do a procedure if you want, like you want to do a biopsy. I mean, if you're doing it alone, I mean, you don't need somebody's help. You open the cervix, open the vagina, expose the cervix. You can do a conization also. You can do a pap smear also, a biopsy also, colposcopy. If I am doing a procedure and I don't need anybody to come in between the patient and, you know, with the another pair of hands coming in between my operating field, so this Cusco speculum helps me more. Yes, I have many other speculums which can help in exposure of the cervix and examination of the vagina, but Cuscos is good for doing procedures. I can do this. So this is what, yes, like my friend is writing here, mednerds, yes, self retaining, correct. It's got a हिंदी में बोलते हैं ना, कसको को कस सकते हैं. All right, कसको को हम कस सकते हैं. But yes, I don't have that correct translation in Tamil for that. So my friends from the south, Cusco speculum has a lock in it. Just remember that much here. Let's move on, guys, and see. This is the sim speculum. This is the sim speculum. We use it mostly for an examination. You know, we just put this one hand, we put the speculum into the antevaginal wall with 2 fingers in the posterior wall. I'll quickly look at the cervix and I'll tell my PG to write my findings. So yes, that's what is a sim speculum. This is a Doyne's retractor. Yes, my intern's favorite instrument in the 3 months of gynecology you've done with us. Yes, you're holding the retractor and you're hanging for dear life during the surgeries. And yes, thanks for all your help. We are able to do so many cesareans. I hope you got to do some closures of the uterine wall at least. The first layer, second layer, did somebody give you that? If you're working hard, you'll get those procedures. And most of you are not going to work in the internship because you feel ki chalta hai, we'll bunk and do work. I mean, we'll do work later, we'll go and read, sit in a PG entrance class, right? Yes, the South Indian language is also there. All right, guys, let's move on. So, Doyne's retractor, and this is the Devers retractor. Devers retractor is the one in which you are, doing a pelvic surgery in depth. So, when you're operating in the depth, then this Devers retractor comes very handy. You know, the pelvis, when you cut the abdomen here and then you're going into the pelvis deep, and so especially you're operating at the walls, you know, you've taken out the uterus and you're operating almost, you know, it's the lower part of the vagina in which you're doing the surgery from the abdomen. You need to retract in the depth. So this Devers retractor comes very handy there. Yes, the surgeons also use this instrument a lot, but we gynecologists love this instrument when we are working in the depth. And recommended emergency conception in India. Look, so far I have not seen any update coming. So I will have to ask you to mark levonorgestrel. I will not say to mark ulipristal. It's a very good promising drug. It is sold as Ella. It is available, off the record. You can get ulipristal Ella in this country. Ulipristal 5 mg is available easily. It is given for fibroids and many other indications, but it is not approved for emergency conception as yet. So please go ahead and mark levonorgestrel. That is the method of choice. Look, do not say IUCD is the method of choice. Never say IUCD. IUCD is a good drug. Only method which works for 5 days. Works into 5 days. But please, this is not the best method because IUCDs require a doctor's prescription and a doctor is required to place the IUCD also inside. But ulipristal or levonorgestrel or COCP, the girl can take herself and she can buy over the counter drug it is. It does not require prescription. So that's why levonorgestrel is the method of choice, because she can just go and buy it and she's prevented from a pregnancy. You're not doing an abortion in emergency conception. That's the reason behind it. When a woman had sex yesterday, today you are just preventing a pregnancy. You're not doing an abortion. That's why this question, and we keep asking you so many times in the exam. What is the earliest when an embryo can implant after sex? It is 6th day, earliest. Even if the sex happened on the day of ovulation, the earliest implantation can happen is on the 6th day. So till 5 days you can prevent the pregnancy. So ideally emergency conception is 3 days and you can push it to another 2 days by IUCDs if it is required. Emergency conception is required for many conditions. Unplanned sex, also girls who got raped, isn't it? So emergency conception can be given up to 5 days. But those 4th day and 5th day, IUCD is going to work very well because it's the most effective emergency conception. It is definitely not the method of choice, because if a girl is having unplanned intercourse, she'd rather take a tablet and be prevented. That's why levonorgestrel is the drug of choice. IUCD is the most effective. I agree. I like that a lot. But we are not going to use it for any person. There's hundreds and hundreds of people who are having unplanned sex on a daily basis. You know that, and I also know that. So guys, for those, you cannot be putting IUCDs every time. That's definitely not the method of choice. I don't know, some place I read that some explanation was also given. So I'm not getting into the details where I saw that. Go ahead and mark levonorgestrel. That is the method of choice. I think you guys saying nulliparous woman. What did you ask me, guys? That was something nice. Nulliparous woman. I don't know. That went off. Okay, that's gone off. So I'll just ask you the next question. Dose of carbetocin used in PPH management is, they've asked you carbetocin. Remember, do not get confused with carboprost. Oxytocin, carbetocin. That's the way to remember. Oxytocin ka bada bhai. Okay, elder brother of oxytocin is carbetocin. So when we talk about carbetocin, that is the drug which is the synthetic analog of oxytocin, and it is more longer acting. Okay, much more sustained action of carbetocin to contract the uterus. That's why it is now becoming a very good favorite drug. I have not said it is the drug of choice. Drug of choice for PPH prevention and PPH management stays as oxytocin. Do not. And what is the drug which works when none of the other drugs work? That is carboprost. If all the drugs don't give us results of controlling PPH, then we say carboprost is the best drug, PGF2 alpha. Okay, that is clear. Carboprost is the best drug overall. So drug of choice for prevention and treatment, oxytocin. If none of the drugs like carbetocin, methyl ergometrin, misoprostol, if they don't work, then carboprost is that big brother which is going to work eventually. But carbetocin is better than oxytocin because of its more sustained action. So it is, what are the dose? 100 micrograms given over 1 minute. Okay, micrograms. I said correct, but I marked wrong. Yeah, microgram, not both are micrograms. Okay, okay, these two choices. So if you mark B, if you mark D, both are correct. One, I can make it milligrams for you live in the session. Milligrams. Yeah, that's the question which will come. Milligrams or micrograms? So we have to mark micrograms. So the answer is in micrograms. So the dose is 100 micrograms in 1 ml given as IV bolus over 1 minute. Okay, because it's got a longer action. Can be given IM also. It is ideally given IV for the best results. Okay. Hi guys, welcome those who are coming. 8. Okay, calculate Bishop score for the following findings when a per-vaginal examination was done for a woman at 37 weeks. Cervix is 1 centimeter dilated, posterior soft, 30%, 1 centimeter dilated, posterior soft. One is not going to get marks, posterior is not going to get marks, soft is going to get good marks. 30% efface, some marks, station at -1, good marks. So yes, did you read Bishop score or not? All you INI-CET students, and if some MCI students are reading this for your exams, please remember, read Bishop score, mug it up and go to the exam hall. Please guys, Bishop score is always coming in the 5 exams in a year. It comes in at least 2 or 3, and one of them in ICT, and mostly the other one is the MCI. Please read Bishop score, mug it up. We are going to ask you, without giving you a chart in front, you have to know the Bishop score. So yes, this is the Bishop score. So effacement, dilatation, effacement, consistency, position, 4 about the cervix and 1 about the station of the head. And the effacement in percentages, we say, a lot of people say the cervical length, because normal is 4 centimeters. So if it is shorter in lengthwise, that is also, basically I've told you many times, what is effacement? The cervix. If you see, look at my hand, this is my arms are the uterus, my palm is the cervix, and the cervix gets slowly effaced. See, this is 50% effaced, 75% effaced, 100% effaced. So that is what is effacement of the cervix. When you see effacement of the cervix, we can say it in percentages also or in the centimeters also. So mostly they'll ask you in percentages. I mean, either way you should know. Most of the time they are asking about the percentages. So yes, if the cervix is 1 centimeter dilated, can you see here? If it is 1 centimeter dilated, 1 mark. Posterior means there are no marks. Okay, and soft will get 2 marks. You see, consistency soft will get 2 marks, and 30% effaced is going to get not marks, no marks, and station is at -1, that will also get 2 marks. So yes, that's why this patient has a score of 5. Okay, all there for you guys. I hope you will remember it properly. Okay, let's move on. The given image, oh, there's a shift in the screen a little bit, sorry guys. So yeah, here if you look at this, the umbilical cord has to attach in the center here. The umbilical cord attaches in the center like this. There is the vein is bigger, the arteries are a little smaller, and vein, you know, is carrying the oxygenated blood. Remember one thing, that it attaches into the center, but if it is attached to the side like this one of our cases which I was doing a cesarean, a nice marginal insertion like we call it. So this is what is known as the battledore. So there's a slight shift. So this is C, the battledore placenta, okay, or marginal insertion. Right guys, now suction shielded lobe is the accessory lobe. I can show you that. Yes, this is again from my hospital. This is the main placenta is here, and this is the suction shielded lobe here. So that is the suction shielded lobe, accessory lobe. What can happen with this one? Yes, the lobe may stay back. When you've done the removal of the placenta, this suction shielded lobe may stay back, and the patient may come to you with a retained placenta, and that is going to come as a secondary PPH later in life. What is the management of secondary PPH, guys? It is a curettage. Then this is a circumvallate placenta. Circumvallate placenta, you see the chorion, the chorionic plate. The chorionic plate is smaller than the amnion. So when this chorionic plate is smaller, chorion matlab placenta, placenta matlab chorion. I hope you don't have any confusion that. Placenta chorion, same to same, no confusion. Placental carcinoma is chorion ka carcinoma, choriocarcinoma, guys. Okay. So yes, chorion is small and the amnion is the usual size. So amnion is folded. So it is doubled on the periphery. So yes, this chorion is small, amnion is doubled. So attachment to the uterus is not as perfect. So there can be more abruption. Yes, and the perfusion will be less because of the small size and the folded amnion coming in the way. So perfusion is not so good. So IGR can be there, but more importantly, many times in your exam, circumvallate placenta associated with abruption. Filamentous cord, yes, the placenta is having a cord attached in the center like it should, but the cord is losing its Wharton's jelly before it is getting attached in the center. So this is the filamentous cord. Oh god, you could barely see it because of yellow color, but never mind guys. So this cord is losing, its protective Wharton's jelly before it is reaching the plasmal margin. So velamentous cord. So that velamentous cord we see many times, but rarely this velamentous cord is over the internal os. So when this velamentous cord is over the internal os, I can make that for you quickly. The placenta is here, the fetus is here, everything is fine. The cord is losing, the cord has lost its jelly, the Wharton's jelly, before it is reaching the placenta. So this you can see the cord is filamentous, but if it is on the internal os here, if it is on the internal os here, then this is going to be a problem, because the baby himself is going to go through this and break the blood vessels and cause bleeding. So velamentous cord can cause a vasa previa. Guys, let's see the next question. Which is the common, it's not question number 16, it is just randomly taken up from some other place. I have taken from another source of PW, so please forget that we are doing more questions than 16. So what is the common obstetric gynecological condition where this procedure is done? So what is the procedure being done here? You can see the procedure done here. There is a clamp here, and in the clamp which is going under an artery, you can see it is the common iliac artery here, the common iliac here, and then this is the external iliac. This is obviously the right side, and this is the internal iliac. Then this is the anterior division here and the posterior division here. So anterior branch of the internal iliac artery is being picked up, and we're going to ligate it. So when you're ligating the anterior division, we are doing it mostly for a patient who's having torrential bleeding in the pelvis. So internal iliac artery is the major blood supply of the pelvis. So please understand, in that case we have to do commonly for a case of atonic PPH, the PPH which is not responding to all my drugs, then my surgical methods of giving a balloon tamponade by Bakri tamponade, or by a Belin suture. I'm trying everything. I did a uterine artery ligation also, but it did not help. Then we have to go ahead and do a internal iliac artery ligation. So yes, answer is B. And remember, when there is patient having this internal iliac artery ligation, we are ligating only the anterior division. Okay, we are ligating only the anterior division, not the posterior division. Yes, INI-CET questions, they will ask what is the very favorite question, what are the branches? All of the branches of anterior division except, all of the branches of posterior division except. So yes, mostly we remember the posterior division branches by this mnemonic SGILLS. Yes, SGILLS. Superior gluteal, iliolumbar, lateral sacral. I used to remember as short gills. Fishes have gills. Short gills. Superior gluteal, iliolumbar, lateral sacral. These are the branches of the posterior division. Yes. Now you guys will mostly like to remember as Shubman Gills. Yes, famous cricketer, and you like to remember that way. Fine. Go ahead and remember whichever you like. But you should know the posterior division branches. As anterior division will be the uterine, obturator, superior vesical, inferior vesical, middle rectal, pudendal. If you can remember that, that's great. But you must remember the branches which is ligated, and ligate only the anterior division, and we are not totally occluding it. We are not ligating the hell out of that artery. We are not occluding the artery. We are reducing the flow by a snug ligature, a ligature which is just reducing the flow, reducing the pulse pressure, so that the flow in the uterine artery is reduced, and that promotes thrombosis in the bleeding bed of the uterus. That's why we are not ligating to obliterate. We are not occluding, we are ligating to reduce the flow. That's the principle of internal iliac artery ligation. Guys, a female during labor presented with persistent occipito-posterior position of the fetus. Manual rotation was tried, but it was unsuccessful. What type of pelvis is this? So if you see the types of pelvis, the gynecoid pelvis rotations are very easy, because gynecoid pelvis occipito-posterior will become occipito-anterior easily. But in a case of an anthropoid pelvis, if you see anthropoid pelvis, the side walls here, they are straight. So this anthropoid pelvis will have these straight side walls, android pelvis will have converging front walls, and anterior posterior flat walls is the flat pelvis. So flat pelvis you will see face. Now suppose there is occipito-posterior in all these three. I'll first show you with this diagram, and then I'll show you on the pelvis. If you see occipital-posterior in all these three, this one, and then in this one, and this one. So the most common type of pelvis, all of you know, is the gynecoid pelvis. And if the occiput, suppose this arrow is the occiput, if it is in the sacrum, occipital-posterior, then this can rotate once, twice, and thrice. 3/8 of a circle, 3/8 of a circle, anterior rotation is possible. So occipital-posterior coming in a case of gynecoid will become occipital-anterior and deliver. Then that is in 80% case of occipital-posterior. Around 15 to 16% case of occipital-posterior, when you see an anthropoid pelvis, this rotation is not possible because the side walls are straight, and this straight side walls will prevent the rotation. So there is no rotation possible. That's why you have a persistent occipital-posterior, which will deliver by an occipital-posterior position itself. So we call it a face to pubis delivery. Let me see if I can explain that to you here live. Come guys, let's see this here. So yes, this is occipital-anterior. Can you see? How do you know it is anterior and posterior? You guys, you know very well. Let me get the light here focused. Yes guys, see this. If you look here, how do you know it is occipital-anterior, occipital-posterior? You will have to see the occiput here. It is above the lambda. Can you see the lambda suture here? The lambda here is the triangular suture, the triangular frontinel rather. So triangular frontinel, it is known as the lambda. It is in the posterior part of the head. So when you're doing a PV and you're feeling a triangular suture, that is the place where the occiput is. So if you see occipital-anterior like this, it is going to go into the pelvis and deliver by extension. See, it delivers by extension, you know that very well. Now, but if it is a case of, let's say, this is a case of occipital transverse, and you can see in your picture it is a right occipital transverse. All right. Now, this is a left occipital transverse. But we are now talking about a occipital-posterior. For example, what is the most common occipital-posterior? The most common occipital-posterior is right occipital-posterior, like I am showing you here. Now, when occipital-posterior hits the pelvic floor, the law of pelvic floor will rotate it to by 1/8 anterior, another 1/8 anterior, and then another 1/8 anterior. So occipital-posterior becomes occipital-anterior and it delivers by extension. Now that is what is happening in a gynecoid pelvis. Now sometimes what happens, this occipital-posterior, look, occiput is in the back of the pelvis and this occiput is towards the back and it's towards the right. So right occipital-posterior is the most common malposition. Most common position is left occipital transverse. Most common position is left occipital transverse. Most common malposition is the right occipital posterior. When it hits the floor, it can become anterior in 80%, but sometimes it stays occipital posterior like this in an anthropoid pelvis. So it will deliver when the sagittal suture, see this sagittal suture is straight in the pelvis. A straight sagittal suture will always deliver. Remember, a straight sagittal suture in the anterior posterior plane of the pelvis will always deliver. Now this is occipital posterior. This delivers by extension again. So occipital posterior, if it stays posterior, will deliver. Although it is not rotated, it will deliver. But now you see, it is delivered by extension. But where is the face looking? The face is looking upwards to the pubis. So please, persistent occipital posterior delivers by extension, and the face is looking at the symphysis pubis. So face to pubis, guys, I discussed face to pubis as a delivery method in a case of persistent occipital posterior. I'm not even talking about face presenting part. No, this is not face presenting part. Don't get confused. So this is occipital posterior, which stays occipital posterior and is delivering by the face looking towards the pubic symphysis. Face to pubis. Right, guys? What are you guys asking me? Lectures are getting uploaded. Sorry about that. We are recording them. NEET students, Ashirwad, yes. God bless you guys. You'll do well. Don't worry. Keep reading. 32-year-old para 2 live 2 lady with history of uterine fibroids with distortion of uterine cavity comes to clinic. She had unprotected intercourse 4 days back and doesn't want to get pregnant. What is your advice? Para 2 live 2 lady, 4 days back, distortion of the cavity. So you ask me a question where you cannot give pills. Pills are not going to work. And there's a distorted cavity. So distorted cavity means you cannot put a IUCD also. But the IUCD, if you put, is going to cause the woman to have irregular bleeding. You're going to prevent a pregnancy, isn't it? Go ahead and put. It's going to cause excess bleeding in the first 2-3 times. Anyway, you're going to wait for the pregnancy not to happen, and then later you can take out the IUCD. Yes. You cannot give any drug. The drugs are not working at this time. You can go ahead and try ulipristal acetate, but that is not legal so far in our country. It is not approved. Till 2025 November, where we are having the stock, it has not been approved. Right, guys? So yes, distorted cavity, placing an IUCD will be a problem. So if you place it, it may get expelled. At least you gave a trial, or you can go ahead and give ulipristal. But kind of questions, yes, that's a difficult one. Okay, the drugs are not going to work. We are not going to say that. Distorted cavity, if she gets pregnant, are you going to do an abortion? So first of all, in a distorted cavity, the pregnancy itself is not going to happen. If this kind of case you're saying with a distorted, the pregnancy itself is a extremely rare kind of thing to happen. Okay. Where is the sex determining region Y, SRY gene located? SRY is also known as the testis determining factor. This is the testis determining factor, SRY, and this testis determining factor is going to decide the formation of a male. If there is Y gene, it's going to make a male. Absence of Y decides to make a female. Okay, so Y makes a male, absence of Y makes a female. Okay, guys. So yes, where is the SRY located? It is located on the short arm of Y chromosome. Short arm of the Y chromosome. So we'll see the Y chromosome here live here. So short arm is having the SRY. This is that light blue band which I'm trying to show you. It is located here. And the long arm of the Y chromosome will have the azoospermia factors A, B, and C. So this azoospermia factors, this is also favorite NEET question and INI-CET question also. So yes, this defects of this azoospermia factor A is the proximal defect, will have definitive azoospermia and Sertoli cell only syndrome, and azoospermia factor B is the most severe form of azoospermia, but the most common form is the distal form, azoospermia factor C. This is the MCQ. Most common type of azoospermia factor deficiency is the site C, mildest condition and also the most common, and we are able to give pregnancies to them, but this will be inherited in boys, isn't it? So we have to understand that these deletions of these areas, this A, B, and C, cannot be done by just a karyotype, because karyotype will just show us the Y chromosome and the X chromosomes. They will not show you the micro deletion. So the micro deletion is done by a multiplex PCR. Okay, a multiplex PCR will show us the micro deletions. Right. Next question, guys. A 56-year-old woman presents to the clinic with complaints of hot flushes and vaginal dryness and itching since menopause. She has a family history of heart disease. She started on hormone replacement therapy. All the following would be expected to benefit, would be the expected benefits of HRT in this patient, except, remember, if she has heart disease, that's a contraindication to HRT. I would have not started HRT in this patient in the first place. So family history of heart disease, she is not having the heart disease in the right now, but we have to be careful. So we'll do an ECG before we give HRT to anybody. So generally we start HRT at 50 when she has menopause, 1 year after the menopause. Please wait for the menopause to be confirmed. 1 year you have to wait. 1 year has gone and she's not had periods, we say she's menopausal, then only you give the HRT, and you can give it only till 60 years. Maximum 10 years you give HRT, because beyond 10 years of use of HRT can be detrimental, can itself cause coronary heart disease. So that's the basics. But please, this HRT cannot prevent heart disease. Rest everything else, hot flushes, relief in vaginal itching, prevention of osteoporosis, all of this the HRT is going to help. Right, guys? So best treatment for osteoporosis. I know you were going to ask me this question, so I kept this one. This is INI-CET November 21. After that, a lot of people who were discussing with me about this management regarding what is the best method of management of osteoporosis in menopausal women, all of that discussion has more or less reduced, but there is a lot of controversy still. So best treatment for osteoporosis women after 60 years. Yes, after 60 years, we are asking you what is the best. Come guys, I want to hear your answers here. Oh, you're already answering me. Imran and Astosh and Rohit, yes, after 60 years. Guys, after 60, what are you going to say? Yes, bisphosphonates. Those who are saying bisphosphonate is correct, even I am also saying it is bisphosphonate, because after 60, you cannot give hormone replacement. But please, before 60 was something else. That's why this question came in INI-CET. This is your question, November 2021. After 60 and beyond, what are you going to give? You're going to give bisphosphonates as the drug of choice. Then what is the drug of choice before 60? As simple as that. It is estrogen. Now, people are going to say that you're looking at this question the way you like to look at. Okay, fine, let me show you data. And the data is always from the books, not from the journals. What is being followed in the clinics, what is being followed in the hospitals, that is the data. Journals have, every new journal will come with a new finding. Till it is accepted in the practice, it doesn't become information for PG entrance students. Do not get confused at all. So we'll get to the books which matter. Shaw's Gynaecology is your reference book. And let me just show you, yes, natural estrogen, okay, osteoporosis management, natural estrogen, progesterone, tibolone, raloxifene are beneficial in osteoporosis if it occurs early in menopause. Osteoporosis occurring late in menopause benefits from bisphosphonates. As black and white and as clear as this, right guys? Let us see the the summary of osteoporosis management given in Shaw's. Estrogen hormone therapy for hysterectomized women. If there's no uterus, you don't have to prevent endometrial cancer, so give only estrogens. With the uterus, estrogen and progesterone, tibolone, raloxifene, even soya bean has come before that. Even soya bean has come before your bisphosphonates. Please do not say bisphosphonates is the method of choice, because in the management of osteoporosis, it is coming so much below. And when bisphosphonate has been mentioned, again they're reminding you for late osteoporosis. Still not convinced? Let's move on and see. Shaw's Gynaecology again. Other drugs for osteoporosis management, like you keep thinking bisphosphonates is the drug of choice. It is coming in the list of other drugs. That means the main drug is already estrogen, discussed, finished. Other drugs ka list mein it is fourth in number. Finally, when they're discussing bisphosphonates, what is written here? Look, they're talking about bisphosphonates finally. It is recommended that HRT should be prescribed in early menopausal age, and after 60 years, osteoporosis should be managed with bisphosphonates. Even more crystal clear. So that's why INI-CET asked you. Yes, you think people in JIPMER and in AIMS and PGI, they don't know about the controversies, but we'll ask you questions which are basic information for students to become postgraduates, whichever subject you pick up after you getting your post-graduation. So basic information clear hona chahiye. So that's why drug of choice is estrogens 50 to 60 years, and after 60 years it is bisphosphonates for osteoporosis. And I can show you many more books. Maybe I'll just show you one more. Novak's Gynaecology. Novak's Gynaecology, this is the 16th edition. Hormone therapy effectively prevents and treats osteoporosis, and it is FDA approved for osteoporosis prevention. The Women Health Initiative trial confirmed a significant 34% reduction in hip fractures in healthy women randomized to hormone therapy. Transdermal estradiol also, forget oral, transdermal estradiol, significant increase in bone marrow density compared with placebos. I can show you still more, but I'll stop. Guys, please go ahead and bindas. Just go ahead and mark osteoporosis management in women with menopause is estrogen therapy or hormone replacement therapy. After 60, we cannot have estrogen because they cause problems. So after 60, we say bisphosphonate. Before 60, go ahead and say estrogen. Estrogens are osteoblastic in nature. Bisphosphonates prevent osteoporosis, but estrogens lay down the newborn cells also. So that's why go ahead and say estrogen. Chaliye, let's move on. I hope I've convinced you with this. A young girl with complaints of not attaining menarche presents with periodic abdominal pain to the hospital. On examination, the following presentation, this image is seen. I've seen this image of one of my patients being used in many forums, but it's all right. I don't have a problem. This is one of my patients where the hymen was bulging like this, and this bulging hymen is suggesting of a imperforate hymen more than a transverse vaginal septum. Transverse vaginal septum is somewhat higher. Sorry for this disarray in the alignment of the choices. So choice A is imperforate Hammond. Of course, the Bartholin cyst is on the sides, Gartner cyst is in the vagina, separate uterus is not seen here, it is seen on a hysteroscopy. So imperforate Hammond, the treatment is a, yes, you know, it's a cruciate incision. Cruciate means cross-shaped incision, because the urethra is here in the opening and there is a cross-shaped incision. If you make a straight incision like this, it'll extend towards the urethra and cause problem. That's why a cross-shaped incision is given. The following regarding non-scalpel vasectomy are correct, except hematoma up to 5% of subjects may occur. Correct. That is correct. Sexual function falling, they are asking all are correct except, so which is wrong. So this is correct. Hematoma in 5% of subjects may occur, correct. Sexual function falling, healing is rarely affected, correct. Sterility immediately after vasectomy, no, not at all. And recanalization is possible, yeah. Recanalization is possible by surgical correction. We can do a recanalization, but the reanastomosis of a vasectomy versus a tubectomy is not so great. I mean, my surgeon friends might not like what I'm saying, but the success is only around 30 to 35%. Some books say up to 50%. But reanastomosis of a tubectomy of a fallopian tube can be as high as successful as 80%. So this is not a reanastomosis of a vas is not done much. I'm not going to get in more in details of that, but there is also a lot of anti-sperm antibodies formed sometimes. So the reanastomosis doesn't give us good results because the anti-sperm antibodies which are formed due to the surgery, the vasectomy which we are doing. So this blood testis barrier is broken sometimes while we're doing this vasectomy. So yes, recanalization is theoretically possible, but it's not a very feasible good option. So the answer here is sterility immediately after vasectomy. Nonsense. It does not give immediate sterility, and that's why we say that the person should be abstaining, not possible, using condoms for good 3 months. So yes, if you see this picture where we are trying to show you, suppose the vasectomy was done somewhere here, vasectomy is done suppose at this site, here you've done the vasectomy, then the area beyond will have sperms. See, this area beyond will have sperms in the vas, and then here it will be there in this for roughly 3 months. So that's why we say it takes 3 months for this area to get dried up of the sperms or 20 ejaculates. So 3 months, or 20 ejaculate. Now, yes, I know your PSM book says 30. Both are correct. Okay. Now, Williams says 20 ejaculates. So, I'll have to say 20. And the reference book for obstetrics and for contraception has to be Williams. Now, if the PSM book says 30, it is not wrong. It's a very good book which is used. Even I read the same book when I was in my MBBS. But more authority and more well accepted, and where the questions on contraception will be made from, will be from obstetrics most of the time. So I'm very sure they're not going to give you 10, 20, 30, 40 as the choice. They'll give you something like 10, 20, 40, 50 like that, or 10, 30, 40, 50 like that. Both 20 and 30, if they give you a choice, bad luck, go ahead and mark what is given in Williams Obstetrics and say 20 ejaculates. Okay, so I will have to say 20 because that's my reference book. So yes, let's see the next question, guys. First sign of magnesium sulfate toxicity. Look, magnesium sulfate maintenance therapy. Magnesium sulfate given, this is a favorite INI-CET question. Magnesium sulfate given for the purpose of stopping the convulsion in eclampsia is 14 grams is the loading dose. You know, we give 10 grams IM, but before that you give IV 5, IV 4 grams. So 14 grams is the loading dose. After that, you must terminate the pregnancy because eclampsia is the worst case scenario in hypertension disorders of pregnancy. So you terminate the pregnancy, reduce the blood pressure by labetalol, but if she delivers today at 8 p.m., she can have convulsions for the next 24 hours still. So we have to give magnesium sulfate till tomorrow evening 8 p.m. Yes, we have to give it 5 grams. Maintenance is 5 grams. Please, the dose has to be read, okay? 5 grams, not milligrams. 5 grams 4 hourly for 24 hours. Guys, please do not have any confusion about which regime to follow. Only Pritchard regime is given and only Pritchard regime is followed and only that is asked. Right from my final MBBS, I'm talking, okay, till then, from then we were told that forget the leans regime and the lytic cocktail and the, the diazepam regime, and all of that has been taken off. We are asking you, and we are also using in the hospitals. Patient has eclampsia, only Maxil is given. You interns have loaded Maxil for us so many times. Interns are loading because so many vials have to be broken. One vial of 2 ml will have 1 gram. So for 14 grams, you have to open 14 vials. Then you have to give you have to continuously this 5 grams you have to give. For 5 grams you have to give 10 ml. You have to give 10 ml of fluid into the buttocks. It's a very painful injection. You interns would have also known that along with this 10 ml, 5 grams will come in 10 ml of solution. So 10 ml into the buttock will hurt a lot. So you add 1 ml of lignocaine also. So you've given so much of Maxil. So don't get into the confusion of other regimes. Okay. So yes, first sign of magnesium sulfate toxicity, the level you have to maintain is 4 to 7 milliequivalents per liter. That is the level you have to maintain, normal level. So first sign is the loss of deep tendon reflexes, which is at 8 to 10 milliequivalents. Breathing difficulty, respiratory arrest is at around 15 milliequivalents, and cardiac arrest is more than 25 milliequivalents. So that is the levels which you have to remember. First sign is the loss of deep tendon reflexes or the knee jerks. A gravida 2 para 1 live 1 lady underwent cesarean section in previous pregnancy for the fetal distress. This time she is pregnant and is having an uneventful vaginal birth after the cesarean section VBAC, but the placenta could not be removed completely. The cord snapped on traction, but the placenta did not deliver. She also started to bleed more profusely now. What is the reason for this? So guys must understand, the placenta is inside and you're trying to do manual removal. It is not working because the placenta is very badly stuck to the uterine wall. It happens because of a placenta accreta. So yes, suction sutured lobe, no, because it's not removed. Inversion, because we have not shown you that the delivery has happened. It generally happens, inversion happens after delivery. Previa would bleed before the delivery. So the answer is C, placenta accreta. Please remember, placenta accreta is happening because of the loss of the Nita bush layer. Okay, the Nita bush. If you see the placenta like this, so when we're trying to remove the placenta, there is a thin layer. There's a thin layer. I made it rather thick here, guys. So there's a thin layer behind the placenta, and that is the area where it's a layer of fibrinoid necrosis. It is normally seen in all the placentas. A layer of fibrinoid necrosis, which is called the Nita bush layer. Nita bush layer. So, oh God, Nita bush layer. Okay, so that Nita bush layer is a normal presence in behind the placenta. So when we do the control contraction, we're able to remove the placenta easily, and that is because of this layer, fibrinoid necrosis. If that is absent, then that is going to cause a very badly adhered placenta to the uterus. So that adhered placenta is known as placenta accreta. If it is going to the muscle, we say it is placenta increta. If it is going towards the uterine serosa, we call it placenta percreta. You know what? Most people end up in a hysterectomy. Yes, there are a lot of sutures. We open the abdomen up and then we try to remove the placenta, and the placenta comes out in bits and pieces. She starts bleeding profusely. We have to arrange for blood. We're trying to give her, figure of 8 sutures and the box sutures, the Cho sutures. There are so many fancy names you guys keep learning. But most of the times, what works? A hysterectomy works. So just hope that the baby is alive, you saved the baby, but even if the baby is dead, to save the mother, we end up doing hysterectomy many times. So this placenta accreta syndrome, PAS, placenta accreta syndrome, this is a big problem. If your patient has this, they end up losing the uterus. Placenta accreta syndrome is not just accreta. Placenta accreta syndrome includes accreta, increta, percreta also. Most common association, yes, most commonly it is associated with placenta previa. That is the MCQ which came in NEET exam sometimes back. Yes, it is also associated with the previous LSCS. Yes, LSCS happens many more times. Yes, So you may see more LACS association, but number of LACS and association, then you may say LACS, but otherwise classically associated more with placenta previa. So Williams is given like that also, placenta previa first, then LACS. So remember, most association is commonly with placenta previa or placenta accreta. We can diagnose this antenatally with a 3D ultrasound and a Doppler. We can diagnose before the patient delivers. So yes, we are ready for this patient. You know, we have arranged the blood, a senior doctor is next to the patient, and we are able to manage it faster rather than managing it as an emergency. So 3D ultrasound with a Doppler will show us this for a diagnosis. Bonus question, guys, come. This patient is having, let's say, shoulder dystocia. Look here, guys, the woman has delivered the head out of the baby right now. What do? You hold the head like this. Yes, you put 2 fingers on the top, 2 fingers on the back of the neck, and you hold the head and give a slight traction. Give a downward traction, and the shoulder comes out of the pubic symphysis. So this is the pubic symphysis, the blue thing here, and the shoulder comes out. Now the head is out, and next you take out the shoulder. But if the shoulder is stuck, we say shoulder dystocia. So guys, what is the first thing to be done? Yes, that's my question. I want your answer, guys. Come. The mother can't give consent for what, my friend? For a hysterectomy while she is sick. Yes, we have to ask the relatives. She's under anesthesia, correct? We have to ask the relatives to save a mother's life. The consent is impossible because the patient is about to die on the table. Can happen many times, guys. And if the patient is moribund, then the next of the kin is asked. Yes, and the relatives, the person who is the guardian, to ask. Episiotomy. Yes, episiotomy has to be given for most deliveries. Episiotomy is fine, but that's not specific for this thing. Yes, specific maneuvers for this. Yes, guys. So I saw one gentleman answering Dr. Swani. Swani. How do you pronounce your name, man? It's a nice new name. Yes, ask for help, correct? Help for everything you do in life. Procedures I'm asking. You know, you're remembering mnemonics of your books. First thing is help for anything. Plus and pre, or do you ask for help? For a topic, you ask for help, isn't it? For anything going wrong, you're asking for help. You're not doing everything alone. Give me specific answers, guys. Yes, those who are saying McRoberts, I'm happy with that. Please understand, we always say McRobert first. The legs. Anyway, the woman, mostly we make them flex the legs, and we ask them to hold the legs and pull them towards themselves and strain. You know, raise your head, clench your teeth, look at your umbilicus and push. That's what we keep encouraging them in the labor rooms, right? So when a patient is in labor and the shoulder is not coming out, we make them flex the hip joint even more. So my intern friends will come handy at that time. We'll flex the hip joint more than 90 degrees. More than 90 degrees flexion of the hip joint is going to make the pelvic inclination better and the anti-shoulder delivers. If that doesn't work, then I can give a suprapubic thump, a suprapubic pressure to disengage this. Or I can turn the baby. You know, I can turn the baby's head while pulling it down. Turn the baby head while pulling. Put your hands inside, hold the head and put your hands on the shoulder like this and turn the baby and deliver the shoulder from the posterior vagina. Turn posterior vagina, turn the other shoulder also from the posterior vagina. Corkscrew maneuver. And if nothing works, you have to hold the head and push it back inside and do a Java Nelly's restitution, that is, do a cesarean section. Yes, there's a interesting new method. It was there in one of the MCI exams recently. It was mentioned as the choices. I think it was MCI or NEET, I forgot. Recently, the exams which happened in July, August. So there was the Gaskin maneuver. The Gaskin maneuver was as one of the choices. Gaskin is all four. You make the woman turn on her force. You know, the hands like this and the knees. She's lying down, not prone. She's with her hands on the table and the knees with all fours. So the weight of the baby comes to the abdomen, and then the posterior shoulder gets disengaged. The shoulder which is at the vagina, we deliver that first. Gaskins, all four. So right, guys, a lot of questions we discussed. I'm here open for NEET exam, nursing student. All right, welcome. I'm very happy. Nursing exam, I think many times, there are some questions which are specific for the nursing exam. I will see your NEET books because I'm in discussions to start an app recording for them, and I'll be able to help you more, but not in the near future. I have to finish my PW work where we are doing the recordings for them. So yes, you're more than happy to ask me questions. Yes, welcome, OY Swani. Very nice to see you here. Anything else? Any questions you have, guys, before we terminate this session as of now? Good engaging all of you, and happy that you guys were here. Love from Arise Jaipur. Hi, Mowgli. So if there are no more questions, I'll keep looking at this in the night, and if there are more people who are asking me questions later, I can answer them even on the chat which comes below the YouTube post. So thank you guys, and keep reading regularly. Keep coming back to the PW forums where we can give you more and more information. Guys, all the best for exams.